Good morning, everyone in Chicagoland, and good afternoon to everyone joining us from New York. And welcome to the Health Outcomes Research Collaborative Seminar Series, Harnessing AI to Enhance Health Outcomes Research. Today, we are delighted to be joined by Dr. Sarah Rossetti from Columbia University, who will be presenting her work on machine learning real-time surveillance system for patient deterioration results from the Concern Early Warning Score trial. I'd like to introduce our team. Rachel Brewington is administrative assistant for the Health Outcomes Research Collaborative, and I am a program director for translational science and also a vice chair for research in family medicine at Endeavor Health. And I would like to just start off by thanking everyone out there on the front lines in healthcare who are fighting the good fight for the health of our populations, and to thank the leadership of Endeavor Health and our Outcomes Research Collaborative for supporting this seminar series. We have three objectives for this series. We want to first share applied AI research intended to improve health outcomes and showcase that work. We want to connect researchers and healthcare scientists across metropolitan Chicagoland to foster collaboration, team science, and we'd like to promote translational science principles and innovation. Our series is really intended to cover the landscape of how we can harness AI to improve health outcomes from issues as broad as medical imaging and optics, predictive analytics, generative and ambient AI, how we apply this in personalized medicine, and as well as a whole range of wraparound services for the care of our patients to really cover the landscape and help us rethink how we can harness this great technology for human good. Next slide. And so the objectives for today's seminar are to first explain a core component of the healthcare process modeling approach to the Concern Early Warning System, interpret how earlier escalation of care influenced outcomes in their study, and to explain steps to integrate clinician expertise in AI-based models going forward. Next slide, please. This is a seminar that really addresses all of the translational science principles we're trying to promote across our CTSA in terms of its creativity and innovation, focusing on unmet needs to capture patients with early warning signs for sepsis and toxicity to help to get them the appropriate triage to intensive care as needed. Generalizable solutions, we think a lot of this could be transportable to our health systems in Chicagoland, and I'm excited to talk later about how we might do that. It's cross-disciplinary work, and it really is at its core about efficiency and speed to make these decisions in a timely way. It's also bold and rigorous, and it's addressing some major health inequities across our system with our complex care patients, and it's boundary crossing as well. Next slide, please. So I'm going to hand this over to Rachel, who's going to talk about the process for obtaining CME credit for today's seminar. Rachel?
Thank you very much, Dr. David. Hello, everyone. To mark your attendance today and claim CME credit for today's seminar, please text the SMS code to the number shown on your screen and now in your chat. Physicians may claim up to 1.5 AMA PRA Category 1 credits based on participation. Other healthcare professionals will receive a certificate of participation. Please check with your licensing board for credit eligibility. The CME flyer attached to today's calendar invite contains full instructions on how to retrieve your CME credit. The same instructions are also linked in the chat. For today's session, you'll be muted during the webinar, but feel free to use the chat to ask questions or share comments. Be mindful of your audience and send messages to both panelists and attendees so everyone can join the conversation. Thank you. Dr. David.
Thank you very much. So an overview of the seminar today. The first hour, after this introduction, we will have our lecture. And during that lecture, we encourage you to put in comments and in the comments section any questions that you have, which Rachel will collect to provide for the Q&A afterwards. And after that, we will have our Beat the Bot, Ask the Professor forum, where we will be reaching out to all of you to get your reactions to the use of open evidence to help shape our questions and apply those to translation of this work towards our own clinical health transformation. And then we'll have some closing remarks. Next. So it's a real privilege to be able to welcome Dr. Sarah Collins Rossetti, who is an associate professor in the Department of Biomedical Informatics and School of Nursing at Columbia University. She's also chair of the AMIA 25x5 Task Force to reduce documentation burden. Dr. Rossetti is a global thought leader on the application of AI to transform healthcare. I saw an amazing presentation that she and others did at the National Academy of Sciences meeting last year. And we're really honored to have you join us today, Dr. Rossetti. And so without further ado, I would like to pass the baton to you.
Great. Thank you. Thank you so much. Let me share my screen here as we get going. Okay, I think, can you see my screen? Great. Okay. All right. And happy St. Patrick's Day, everyone. Happy to be presenting.
You're wearing green. Well done. Thank you.
Yes. Oh, yes, definitely. Had to get my kids in their green shirts today, so made sure to find mine. Okay, wonderful. So I have no relevant disclosures to report, and I think you've seen these learning objectives as well. As we get started, I'd like to acknowledge Dr. Kenrick Cato, who is multi-PI of this study with me. We have been collaborating on this work for, we're going on 15 years now, and just about 10 years funded from NIH, and about 5 years funded from the American Nurses Foundation. So really fortunate to have that funding to make this happen. I'd like to start with this quote. There's a great difference between worry and concern. A worried person sees a problem and a concerned person solves a problem. And really at the end of the day, that's what we're talking about here, and why the data that we're modeling, we're able to model. You know, and we're certainly focused on nurses concerned in this study. You know, I think I'd say likely most clinicians, you know, operate with this sense as well, I think. So I like to think of the electronic health record data as a flipped iceberg. You know, I know we certainly have some clinicians on the call. I also, you know, I used to be a practicing ICU nurse. My research now also focuses on documentation burden. We know that there's a lot of excessive documentation burden. That's entries with, that's problems with our data entry, certainly, that's excessive, but what that also results in is information overload within the chart. So going in and looking at the chart to find information, there is a lot of noise. So naturally, actually, data scientists see this noise as well. And what does this really mean? Well, if you think about the EHR data as a flipped iceberg, and if the bottom of that iceberg is then at the top, then all that noise, that's what we see at first. That data, interestingly, lacks variability. So much of it looks the same across patients, particularly when we're talking about nursing data, because nurses' documentation burden, a bulk of it is recording standard of care, which then is the same for all patients. So that's not really the information driving care decision-making. It's information that's not driving clinical decision-making, because it's the same for all patients. If everybody's, you know, getting the same types of, you know, safety measures recorded for themselves and so forth. And the plan of care for nursing, we know, you know, the structure of it really doesn't provide overall direction around what really that patient's problems are. And in my research, we've spoken with nurses to a very large extent around this problem. They still absolutely engage in care planning, but the care plan structure in the EHR, by and large, is not reflecting those actual decisions. And so these data end up with a lack of a statistical signal. But what's interesting is when you look beneath the surface, there are signals. If you look at where the variability is, we have been able to find nursing surveillance patterns that are based on changes in a clinical state and have a statistical signal. And so when you think of it not from the process of what's required to be documented, but what is the nursing practice that nurses engage in, you're able to then unearth these signals. And so what you see here at the bottom there, that's the nursing process, and certainly used by other health professionals too in this general process of assess, diagnose, plan, implement, and evaluate, and back to assess. So what have we really been able to do, and what really spurred this project? Is that we know that nurses' increased surveillance patterns are an early predictor of adverse events. So as I said, we started this research 15 years ago, and we looked at the increased frequency of recording vital signs or recording a comment associated with a vital sign. And was that associated to patient outcomes such as cardiac arrest and inpatient mortality? And we found that those associations were there. And so it really did prompt us to model out this data, and just to really kind of reiterate, looking at these data from the beginning was based on clinical hunches of me working clinically in the ICU and seeing how, as I was a new nurse, observing how more senior experienced nurses were documenting, and that when they were worried about a patient, there was certainly a higher volume of data captured versus not. And when I started, there were paper-based flow sheets actually. And so you could really see it visually right in front of you, all the white space for a patient that really the nurse was not concerned about versus a patient that clearly at handoff, this nurse was worried about. And that really struck me as I began working clinically and then worked in a variety of hospitals and saw that these patterns continued. Plus, I also engaged in those patterns. And so what we have found is that when we look at the temporal patterns in EHR data, specifically entries with increased frequency of documentation and entries done at uncommon times, that reflects a nurse's concern about a patient in the hospital setting, concern for deterioration, such as sepsis, cardiac arrest, mortality, or need for a rapid response or a transfer to the ICU. And so when we've actually modeled this as a predictor, we've been able to predict patient deterioration and adverse events in the next 2 days. So we actually turn this into an early warning system where we model these tacit knowledge and expert behaviors for those changes in nursing documentation patterns, have incorporated that in an AI-based prediction model. So using multinomial gradient boosted machine learning model with a prediction accuracy of over 97%, both acute care units and ICU. So the concern model is used both in the ICU as well as acute care units. And we'll talk about what we've looked at for outcomes for the two of those. It's actually an ensemble-based modeling approach. And so what that means is it's many different models. And so we have about 1,200 models within the concern system. And so, for example, we incorporate a lot of temporal information, like the day of the week, is it day shift or is it night shift? And much of this relates to looking for common patterns versus uncommon patterns. And so we have, for instance, a model for a patient who's on their hospital day 2 in the acute care unit, and it's the middle of the night on a Saturday night. And so that model knows certain characteristics, of the patient and kind of that point in their stay and the typical patterns of nursing documentation at that point in time, and then can identify when those patterns have a signal in that there is some uncommon, documentation occurring, which can be a signal for a nurse's concern. And so we've baked this into a real-time clinical decision support in the EHR, and we've gone live at several sites with the Epic EHR. And what you see here is what's displayed, the first display to clinicians in their patient list. So it shows a red, yellow, or green score. So red is showing signs of deterioration, yellow is increased risk for deterioration, and green is low risk for deterioration. And we'll talk about how we arrived at that particular screen. And so the point of this slide, I just talked about these scores, but is to really talk about when we were building out this model, we worked very closely with clinicians, both nurses, physicians, NPs, PAs, those clinicians that are on these hospital units, to determine, what are we actually intervening on? And we became very clear on the fact that we're intervening on shared team situational awareness here. We're modeling a nurse's concern for patient deterioration, and we're displaying this risk score to the entire care team for the purpose that they all get on board about what this level of concern and level of risk is, so that they can have these early conversations about what that patient needs. And this was really important because our model displays the risk score, but it doesn't provide recommendations. We're an all-cause deterioration model. And so we're not saying it looks like your patient has sepsis and therefore, start your sepsis protocol, because again, it's all-cause deterioration. And so what's important is for the care team to get on the same page. We'll talk about too how our model is shown to have better lead time than other models. So what this means is that these are early conversations. So this is about 2 days, it's been shown to predict these risks 2 days before an event. So these are early conversations for the care team to have to get on the same page about this patient's level of risk. And in our implementation, it was really important to be clear that we're not changing escalation of care protocols here, but we're giving this additional data point so the care team can discuss this and then engage in the existing escalation of care protocols. And that was really important discussions with leadership, as well as training points with clinicians when we were going live. Okay, so we evaluated the concern early warning score in a clinical trial, and this was published last year in Nature Medicine. And so there were just over 60,000 patients in this trial. It was a multi-site, pragmatic, cluster randomized controlled trial. If you look at the dates of that trial, it was October 2020 to October 2022. So certainly some interesting years for our overall US and world healthcare system. It overlapped with the COVID pandemic. We were actually delayed in our implementation originally by a year because here we were at Columbia, we were going live with the Epic EHR system. So we delayed our implementation there. And so it was a 1-year trial at each site. First up in Boston, Brigham and Women's, Mass General Brigham system went live. And then the year later, we were live here at Columbia. But in total, it was 74 units. And we randomized at the unit level. And so it was 37 and 37. 37 units were in the intervention group. So that was all of the patients in those units had the concern score displayed for their care team, and then in the usual care units, those patients did not have a score displayed. And if you look at our paper, there really were no significant differences between the groups. And so what we found is a 35.6% decreased risk of in-hospital mortality for patients whose care team had access to the concern early warning score. Over half a day decrease in length of stay, a 7.5% decrease in risk of sepsis, and very interestingly, an increase of it by 24.9% in transfers to the ICU. So this was we were overwhelmed with the clinical findings for sure. That was extremely exciting. And then this transfer to the ICU finding was really interesting as well. And so we're going to dig into some of that. And I'll start as I talk about the ICU transfers. First, I want to start by noting that once we saw when we saw that finding, we of course went to the literature, and the literature is really interesting around ICU transfer. There were no good definitions of it. So some studies use ICU transfer as an outcome, some use it as more of a process measure. But what is not well defined is a good or bad, and some interpret it as a good thing, and some interpret it as a bad thing. And it's not good or bad; it's actually more early or late. But that's what's hard to measure is early or late, because early or late transfer relative to what? Ultimately, we're talking about deterioration. And deterioration is very hard to measure. You can measure those outcomes, but how do you measure a patient on this trajectory of deterioration? We've never really had or have a measure of it. So if you look at the literature, it becomes kind of clear why there aren't good measures of was this an early deterioration or an early ICU transfer or a late ICU transfer. Now, saying all of this to any of the clinicians on the call, it's probably fairly obvious that an early transfer is better and late transfers we would like to avoid. From a clinical perspective, an early transfer is more controlled environment where we can intervene early and hopefully stop any physiological processes from happening when you're in that more controlled environment in the ICU with better level of intervention. The late transfer, you're trying to play catch up on that patient who's already reached a point that can be really hard to have actually effective interventions to bring them, back to a healthy state. Okay, so we wanted to dig into this data. And so what we did for that, what you see here are all the patients in the trial. So we said, okay, let's look at the data set that we have. What do we have for all of these patients? And in order to, so first we just looked at, okay, what were the rates here for, for mortality for our unplanned transfers? And in our concern intervention group, it was 16.9% for mortality and 24.7% for mortality. So more, higher mortality in the usual care group for unplanned transfers. And I should add, we were clear on our definition of unplanned transfer. That's going from an acute care unit to an ICU. It doesn't include at all patients coming from the emergency department, and it doesn't include patients that were coming from the OR, or the PACU, who had some sort of planned procedure. And so what we found was that for patients that were in the concern group, they had a 37% lower risk of who had an unplanned ICU transfer. They had a 37% lower risk of in-hospital mortality. We're getting at understanding the group more, but we wanted to understand why. We also looked at length of stay for unplanned ICU transfers. And we found that, so that for the concerned intervention unit, they had a lower length of stay. And this was particularly true for those with a higher Charlson comorbidity index score. And this is just another way to look at that data to show that they did have a significantly decreased length of stay in the concerned intervention units. So we were thinking, okay, so what is really the mechanism of action there? And apologies there. What I wanted to also note is that we then did look at the data for just patients on the concerned intervention units, and we found that those that were transferred later than 36 hours after their concern score changed, they actually had a much higher risk of mortality. And so we were able to demonstrate that using when the concern score changed, the actual that the early transfers for our concerned intervention units really made an impact on their risk of mortality. So I want to talk a little bit about the features within the concern model, now that we've seen some of the outcomes. And so what we actually look at are vital sign entry frequency, vital sign comment frequency, the frequency in which some medication administration record data is documented, the frequency in which some nursing note data is documented, and then also in some of our models, we've used natural language processing to look at nursing note content. What's interesting about that is that the signal from natural language processing is not actually the strongest signal and not really needed in the model in order to have good prediction accuracy. And so what we've found is implementing at other sites to just use the structured metadata is good enough. And so, you can see here that these are all frequencies. And so, the core part of our model really is not using the patient's actual vital sign or, the actual content really that's the data that's being recorded, but it's the act of the nurse recording this data. So it's the nurse's behavior to actually record this. When they, for instance, if they're worried about a patient because they're walking into the room more frequently, they're assessing more frequently, and then they're recording that within the EHR. We then include a lot of information around temporal factors. I had mentioned before, the seasonality is important, the day of the week, is it day shift or night shift? Because these things all actually really impact the expected patterns that nurses have in their documentation versus, when it is more of an uncommon type of frequency. I'll point out too around MAR frequency, that's the medication administration record. We found that there are some specific types of medications that have an interesting signal to them. So for some PRN medications, when the nurse gives those medications, these are as needed medications, that can be a signal of concern, which you might expect. A basic example would be giving pain medication when the patient's in pain, or Tylenol when they have the fever. There's some element of a patient change in their state here. But also to look at medications that are withheld. And so nurses, a good example is if a patient has a blood pressure lowering medication and the nurse chooses to hold that medication. This might be an example of a patient that is typically hypertensive. And so their baseline is a higher blood pressure. And so they're typically on blood pressure lowering medications. But now that they're hospitalized, they're not at their higher baseline, and the nurse may be observing this. So if they seem to be in an unstable state and their blood pressure is not particularly high, it's low, it may be within a normal range of a blood pressure, which typically would be ideal for a patient. But maybe for this patient, what's different is that's not their normal. And so the nurse is noting that, and the nurse may hold that medication until there can be a conversation with the care team around that, because the nurse doesn't want to bottom that patient out, and they're worried about why are they not near their baseline, what's going on there. And that's been a strong indicator, that type of example in our model for being able to model nurses' concern. And then we certainly include different categorical features like demographics, where the patient is in the hospital. And I had mentioned other things like the time of day. And this turns into a score that's between 1 and 10. But we worked really closely with clinicians and realized very quickly a score between 1 and 10 is not very useful, because what's the difference between a 3 and a 4 or a 7 and an 8? And so we landed on transforming that into a green, yellow, or red. We worked on the concept of AI fairness in looking at our data and how and the scores generated, the outputs generated across different racial groups. And so what we did find is that there were differences between groups of Black patients and white patients in terms of the output that was generated, the average score generated. You see the same thing between for the Muse score and the National Early Warning Score, which are kind of some of the leading used early warning scores across our country and other countries. And so the reason, we see this is we know that EHR data has biases in it. We're modeling these patterns of documentation. And so if you just model those and you don't take into account that there are biases, perhaps in the frequency of attention in different regards for, some across patient populations, then you're going to have bias in your model output. And so we corrected for that in the concern output to make sure that we weren't propagating that bias. Now, I think a really important point on this is we don't at all claim that this is a problem solved in terms of the concern score and AI fairness. This is a complex problem, and I think AI models are still figuring out the best practices for this. And so we hope to, keep up with this, but the methods around it too are still being, figured out and optimized. We also did look at primary language spoken, and that was also significantly different in terms of populations for our outputs. English versus non-English is how we looked at that. So these are really, really important issues to be upfront about looking for and then figuring out what is a good approach to mitigate it. We worked on decreasing alert fatigue. And so our output is red, yellow, green. And from the beginning, we were saying, okay, we are focused on increasing shared team situational awareness. We're very clear on the fact that we think the whole care team is going to know who these red patients are already. So that's not really our focus. And so we didn't want to be over alerting. And so we aimed, and we actually set some goals to have the red patients be no more than 2% of the population on the unit. The yellow patients about 20%, and then the rest green. Because anything more to that, if there were more yellows in your list, how do you really prioritize them? Because at the end of the day, our risk score is about patient prioritization. And we know that, physicians who are working on the unit or, your overnight resident, how would this be useful if 80% of the list were yellow? That doesn't really guide you in this being an additional useful data point to direct care. One of the ways to think of this too is, we're modeling the nurse's concern. So presumably the nurse is aware of these patients. And what we've found when we look at the acute care unit is in some of the data is before our intervention, when we just look at modeling nurses' concern in the ICU, when you see those patterns of nurses' concern, patients did better, again, before our intervention, when you're just looking at the patterns themselves. But in the acute care unit, patients did not do better. And so in some qualitative work that we've done over the years, we really identified that this, like many patient safety problems, comes down to communication. And so if the nurse and the physician are not co-located, it can just take a longer time to communicate about this concern for this patient, particularly if this is an early concern before vital signs are changing. And you have, very frequently, maybe it's an overnight resident who has a very long list of patients to care for and to prioritize. And so it can be very hard to prioritize a patient then that doesn't look sick based on all of their physiological scores. And so that's really what we're trying to intervene on. This, nurses' concern has for many years been identified as a reason for calling a rapid response or escalating care, but it didn't have an objective measure behind it. And we were able to measure that. And so that's the utility of it in bringing it into a data point. And so that's why this slide was actually so important to get this right. Because if there was alert fatigue, it would not be providing the information that ultimately we were trying to provide. What you see on this slide there too is that we did some score smoothing, this hysteresis analysis. So what that means is that it's not easy for a patient to go from green to yellow Sorry, it's not easy to go from green to yellow because we don't want them to have to be able to bounce back to green. Or so if they're going to yellow, it's not going to be easy for them. We don't want them to be bouncing back to green and back to yellow and back and forth. So, and the same from yellow to red, because that's not going to give a lot of confidence or trust to clinicians in this score. So, so we don't make it easy for the scores to bounce around like that. And I also probably should mention, and this is a good slide to do it, when you look at our final design, I'll talk about the low fidelity design in a minute, but the final design on the upper right-hand corner, what we provide is that score plus an asterisk. And the score is run every hour for all patients, on the unit or on the units that are live for that hospital. And the asterisk tells you if the score has changed in the past hour. And so this slide here shows the extensive user-centered design that we did with nurses and prescribing providers. So you see the low fidelity prototype in the bottom left. We were trying to show the comparison to Muse at that point. That's certainly not, a display that you would actually display to clinicians, but I like to include this because, here we were with a predictive model and you have an output. So it produces some numbers. We had to figure out what then to translate that into. And so it could have been numbers, it has 12, 19, but those really, that's too big of a scale, too meaningless to clinicians. And so we had to do that work to present them with, in low fidelity ways, what would you like this to look like? And then what's the actual information that's useful? And then, okay, within that information, how's it actually digestible and interpretable so that you can, make sense of it and take clinical action. And so what we landed on is that final design that you see there, where it's embedded within the patient list, which is the landing page. Now we developed it with kind of the future proofing to it, if you will, that what we do is we write back the score to a flow sheet row within Epic. And so it could be displayed anywhere in Epic. So we're not tied to this patient list design if in the future there ends up being, a more important module that is then used. And, and we've heard that here and there from nurses, for instance, they use the brain as kind of their, home, main landing page. And so it could be incorporated into any of those areas. And I'll also mention, we use FHIR interoperability standards so that it could work with other electronic health records besides Epic. So this is then the screen that clinicians are able to drill down to. So I'll go back for a second, they double click on that regular green icon if they want, and it brings them to this screen. We realize that not all clinicians will come to this screen. Clinicians are busy. Sometimes that regular green will be enough. But we wanted this information to be present and available to them. And so what this is this is the concern detailed prediction screen. You see, certainly the patient information up at the top there, noting this is a high risk. You see up in the top left corner, just information about our study. If they had any questions, certainly important to be able to contact us. What you see in the middle there are what we call the factors. And so the features in our model are then grouped into these 5 factors. The main features, really, clinical features that are driving this prediction in our model. We group them into these 5 factors. And then what we do is we display this in a ranked order of the ones that are weighted most for this particular patient's score. And the information that's there is actually pulling their EHR data. So that the clinician can see, well, what was it that was recorded that was driving this score, as a way for them to really understand a bit about that particular patient's prediction. You can also see the trend on the right-hand side there. You can go back to 72 hours to see what that patient's score was. And then you can see where the patient is relative to other patients on the unit at the bottom there. So this screen here, again, not all clinicians go to it. No, a clinician doesn't ever have to go to it if they want. They can, like I said, use that red, yellow, green icon in the patient list. But if they do go to it, we did build in a user log of the use of that detailed screen. The user log of just the score being displayed in the patient list is via Epic user log for tracking. That's a little bit harder to really figure out. You can know when they're on their patient list, but there are other things, perhaps on that screen or that they're doing. So what we are able to look at is of those users, again, it's not all of the users and it's just a small percent, but that go into the detailed prediction score, what can we learn about them? So we looked at that data for our trial. And this was only for those, obviously, that those patients that had the concern intervention, because we're looking at actually access to that concern screen. And so there were 1,200 patient encounters that had at least one click into this detailed prediction screen during their stay. At one site, it was certainly more, just over 900. And then at the other site, it was 320. And so then of those, there were a total of just over 2,500 launches of the actual screen for 393 unique clinician users. Okay, so we can look at some of this data here, and what we find, there are some differences across the two sites in, how many launches there were per any of these users. And you see at one site, it was on average 8.7 and the other site 2.7 users there. If we look at who the users were, the majority of users were nurses. OP is ordering provider. And so certainly a smaller percent, though at one of the sites, it was nearly evenly split. At our other site, it was majority RNs at 80%. And then we looked at who these heavy users were, because we wanted to understand, what something about them, who was doing that, who was drilling into this screen most often. And so again, that was, split, a similar split. Overall, mostly registered nurses, but one site was, again, closely evenly split. And then at the other site, it was 80% nurses. We did look at these heavy versus light users in terms of patients' Charlson Comorbidity Index. And we found that at one of the sites, the heavy users launched this detailed screen for patients that did have slightly higher Charlson Comorbidity Index than the light users did, And then these overall counts by looking at shift type and by unit type. So overall, these launches were happening during the day. Again, some differences there between the sites. And then most of the launches actually, and this was similar across both sites, which is different than some of the other data, was on the acute care units. So what can we learn from this? That overall the users of it were nurses, same with the heavy users of it, if you will. The launches mostly occurred during the day shift and for acute care units. And we did see variability between the sites. So there could be some potential differences in workflows or team dynamics in terms of that, something interesting to kind of, look at in the future. But certainly a lot of limitations around this. That this launch, again, is a proxy of usage. You really can use our score just on the patient list. So it's only looking at 3% of eligible encounters had one or more of eligible patient encounters had one or more launch. So it's a tiny sliver really of the usage, which is important to know. But because of that, we were able to determine that most of the usage of our tool is passive, then, if you will, that it's viewing the score on the patient list as opposed to drilling down. And so we're working on scaling and spreading concern. We've been working on this for a while, actually. So starting a couple of years ago, we started transitioning the architecture of the entire early warning score into a Docker architecture. And Kenrick Cato really is the master behind this. And this was with the vision really of having it packaged up nicely to be able to deliver to other health systems for implementation. As it turns out, as years rapidly go, a lot has changed in the past few years, at health systems. And so now many are more comfortable using cloud-based solutions. And so that's kind of been an interesting finding of ours from what we were, technically planning and changing a couple of years ago or a few years ago. And so, we could start to look to a cloud-based solution as a possibility, because really that is more amenable to health systems now. But really at the time we were making those decisions was not kind of as easily or positively done. We do have a monitoring tool that we have built, and this is monitoring of the model, really. And so this is to look at things like data drift, and to know that it's running for all patients, and that it's running as we expected, and that the performance is as expected, or to be able to probe into if it's changed. And sometimes something like this for our model could be as simple as they've changed a flow sheet row, or retired a particular flow sheet template, and then would need to understand how that impacts our data input. And so we've built out a toolkit that is open and posted online. And it's open in the sense that you just need to register, but then can access all of this information about resources about implementing concern and how to get started, and the types of PowerPoints that you can use to pitch this to your executives, if you're interested in that, all the kind of the governance committees that you'd need to go to, resources, for those types of presentations, as well as information about technical implementation. So everything's on there except the actual software. And so what we've decided to do is, at this point in kind of our journey, we're very open to any sites that are eager to implement this, would love to work with you. We would, up to this point, we've implemented just at sites where we've had research funding to do so. And so naturally through that, you have all of the contracts that go with it, and you're able to proceed and go along. And so we'd be happy to engage with any sites that are interested in this, and just enter into an academic research license for that point. And, we don't have research funding for other sites, but if a health system was willing to absorb any of the implementation costs, which are relatively, low, compared to some things, then would be happy to proceed. So, if you're interested, check out the toolkit, and we could talk. We have been funded by American Nurses Foundation to implement at Washington University in St. Louis and Vanderbilt University Medical Center. And so this is really important work for us. We're able to get out a lot of the kinks of that actual process of, transporting this to another health system, from technically how to do that, from a governance perspective, how to do that, seeing the similarities, the differences between really, it's interesting, all of the evolving AI governance structures at health systems right now. They've certainly been changing a lot over the past couple of years. And then also to be able to look at, how well does this run, on a different data set. And actually, to that point, I want to point out that, and we have those go lives are coming up this year for those sites. So really work that we were thrilled happened, and we didn't initiate it. These wonderful colleagues of ours at University of Utah did. They took essentially an earlier publication of ours, describing the concern model, and then ran that, configured that for themselves, and then ran that on the EICU data set, which is over 200 hospitals, an open data set of over 2 ICUs from over 200 hospitals, they were able to find that it performed well. So really demonstrating the reproducibility and generalizability of, really it's the concern modeling approach, or as you see in this paper, talked about the healthcare process modeling approach, for detecting signals of nurses' concern. Because again, it wasn't the exact same advanced model that we deployed in the trial. It was a much more simple model looking at these frequencies of nursing documentation and how they relate to outcomes. And they were able to, show that it was pretty well performing, which is exciting. So showing that these nursing practice patterns are reliable across organizations, across our health system. When Kenrick and I started this work, we would always say, we want concern to be in every hospital in the country. Because if it works, then we want it to be. And so, it's pretty exciting to have data to show that nurses document this way in a consistent way. This is a core part of nursing practice, that we're able to model these behaviors and really use them, in a useful way for prediction. I'll add too, I used to have, when we first put our first papers out, nurses emailed me out of the blue saying, yes, I document that way. That is how I document. That's my practice. When I'm worried about a patient, I know I do that, which, to me, obviously that's, an N of one here and an N of one there, but really kind of phenomenal to hear that, from nurses that they know they do that, and we were able to model it. So I think that there's a lot of possibilities for how this type of data can be modeled and how we can model nursing expertise in this way. But I don't see why there's I don't see a limit to, let's look at other types of clinicians' expertise and how we could model that as well, thinking of it with this type of framework. So we are looking at actually labor and delivery. This is inpatient data, so for the actual labor and delivery stay, including postpartum, and collaborating here with the Perinatal Research Consortium. So this isn't implementing an early warning score, but it's seeing if we can model the data with that same approach for predicting sepsis, as well as other maternal morbidity outcomes. And we're also extending to inpatient pediatrics, including at some community hospital sites, working with University of Colorado for this. And what's interesting about this is, in this case, you certainly need to identify the appropriate pediatric outcomes. And doing that, we're also working with family caregivers to see how we could start to prototype out a way to capture their concerns and their input. It's been really wonderful working with this pediatric community. They're really enthusiastic, and I think also eager to have, an early warning score that works and an AI-based one they'd be really excited about too. But, it's a really important clinical area, and we've certainly learned that in talking with them, that they've wanted, a way to actually predict, when a child needs an early ICU transfer, and that is actually a outcome that they have of looking at this early versus late. So they actually are a community that has looked into this, and defined this issue of early versus late, and they have a nice definition of that outcome, operational definition of that outcome. And so, we're doing the feature engineering for that model right now, and we really are very hopeful and hope that it can have some good performance to it. So I want to take a moment here towards the end to talk a little bit about kind of the broader perspective. And, I mentioned at the beginning, my work also has to do with documentation burden. So sometimes I'm posed the question of, okay, you're looking at, these frequency patterns of nursing documentation, but the other 50% of your time you research how you can reduce documentation burden. Because I don't see, in my mind, they don't conflict at all. And so I want to kind of talk through some of what I'm thinking around there. So in terms of documentation burden, we're quite hopeful for tools such as ambient listening and perhaps generative AI. We'll see how that plays out for decreasing some of the problems with excessive documentation burden, so offloading some of that burden. Now, this is not, problem solved and we're going to implement these tools and then, the joy of medicine and nursing comes back, and it's as simple as that. By no means. We need to remain vigilant of unintended consequences, new burdens that might be introduced, changes to clinical workflows, and practice changes. I think what we know right now from pilots that have happened across the country, I know certainly a large extent of pilots for physicians in different settings, and some pilots for nursing, is that ambient listening perhaps can bring that joy back because it's offloading some of that manual data entry. But there's still a lot to be figured out. Not every clinician loves it that's used it so far. What works well, what doesn't work well. I think that the burden perhaps now is so excessive and still a lot of manual work that it gets you pretty far, but we do need to be careful in how these are really designed. I do anticipate, and there's been some interesting pieces written about this. Max Topaz has put out a recent perspective that was interesting, that it really most likely will change practice patterns in very interesting ways that we don't know exactly how that will play out. And so I think a lot to be investigated there. Now, in the context of concern, I'm really, and I know Kenrick is too, we talk about this all the time, excited to model that data, as it's newly captured through these new AI-based tools. We're excited about it because what concern does is it models the nurse's behavior. So we don't feel that we're tied to, nursing flow sheets and these particular fields and anything in the realm of required documentation. We're really modeling what the nurse puts in above and beyond the requirements and this behavior pattern that seems to be pretty reliable, as we saw, in that analysis of the EICU data set across 200 hospitals. So I think that, we know a lot's going to change over the next, I don't know, I don't try to predict, but 5 years, probably there will probably be some new practice patterns with our new tools that are used to capture data into the EHR. And so it will be interesting to be able to model that data. And I think if we approach it from modeling the behavior of nurses and perhaps other clinicians, we could find some really interesting information. The other thing I want to point out is the N burden study, which I lead with Po Yin Yen from Washington University, St. Louis, and this is funded by AHRQ. And so in this study, we were able to do a natural experiment of essentially documentation burden. During COVID, documentation requirements were relaxed for all clinicians. For the most part, it was just medications had to be documented. So medications ordered and administered. But overall, the requirements for nursing documentation, were up to the nurse for the most part. And so we were able to show that when this occurred compared to times when they were not relaxed, that nurses did, in fact, as you might expect, documented less regulatory information. Especially those that are really just capturing the standard of care for all patients, such as patient repositioning, safety equipment at the bedside, the fact that the patient's armband is on. But nurses continue to maintain consistent levels of data capture for what we really, in qualitative work too, were able to call, that decision, clinical decision driving information. So they were still recording vital signs at the same high frequency and respiratory assessment, neuro assessment, and so forth. We're actually currently in our AIM-3 of the study evaluating to see if there was any influence on outcomes. But what we know now is that when nurses are free to decide and still under high workloads, such as during the COVID pandemic, they streamline their charting to focus on information that drives care decisions and team communication and coordination. And ultimately, that's the type of data, that nursing surveillance data, that we're modeling in Concern. And so I'm very hopeful for our ability to continue to, we haven't done enough by any means, and the needle has not moved, but decrease documentation burden for our clinicians and be able to model these behaviors that they engage in, because it's not tied to those required documentation points and that excessive burden that we impose on them. So I think there's a lot we can do in the future. It'll be interesting to see how that data looks when we have, AI tools to assist the input. But I'm excited to do that work, and I think there's a lot of opportunity. Again, just landing on a reminder of this, it's that signal that we're going for. And I'm hopeful that, we can continue to work to get rid of some of the noise in the record, because really the modeling that we've seen successful is with that signal. So in summary, nursing surveillance patterns are a very useful signal. Nursing behaviors are valuable early signals to predict deterioration of hospitalized patients, to overcome the limitations of physiological measurements. We're able to use existing data. The concern model doesn't ask nurses to document any additional data points. We fully integrated this as a real-time early warning score and did that trial with a very clear intervention was increasing team shared situational awareness. We were focused on all-cause deterioration and able to predict it up to 2 days earlier than other early warning scores. And I really identified this early ICU transfer as a window of critical opportunity for timely interventions. And right now we're working on our scaling and our spreading. And then I'm also thinking of, as I said a couple slides ago, how to really continue to model the data that comes in that is using some of our newer AI-based tools as we see that happening. I want to acknowledge the concern team. It's an amazing team to work with that has grown significantly over the years, and our funding, absolutely. And also I mentioned some of the findings from the end burden study as well. And I'm going to stop there, and I think I'll stop sharing. Okay.
Thank you very much. That was incredible. I'm going to hand this over to Rachel for Q&A.
Thank you so much. We're going to go straight to the chat we have a couple of questions there. Our first question is from Dr. Susan Fisher. When you were looking at outcomes using multivariate models, did you consider nurse-patient ratio in the effectiveness of your model?
Yeah, that is not, so the answer is no, that is not actually factored into our model. Great point. And, it would be something interesting to look at. We've talked extensively about incorporating nursing characteristics in, that's kind of slightly related, things such as level of nursing experience as well. Those are hard to get reliably directly from the EHR in real time. And so we haven't approached that. And the same with the nurse patient ratio, that can change dynamically. It's not that it couldn't be done. We just didn't tackle that.
Got it. And I'm so sorry, I missed her first question. Any explanation for the difference in users between the two sites? This was around slide 26.
Go to slide 26, see what that one was. Okay. I don't know that I'd venture in explanation for the difference in users. So for everyone on the call, we're talking here about the user logs of the detailed prediction screen. And again, this is only about 3% of the patients in the trial, of the encounters did clinicians click into this detailed screen. Otherwise, they just used red, yellow, green and knowing if the score changed in the past hour from that asterisk. But this is the logs of saying that at one site, it was almost evenly split, 46% nurses that were using this detailed log and 48% ordering providers. And at our other site, it was 80% nurses and 18% ordering providers. I don't have an explanation. I mean, we know that different workflows vary at different sites. And certainly it could be related to training as it occurred at different sites as well, which certainly can have some level of variation to it. I mean, we had consistent training materials, but yeah, I'm not sure. They're relatively small numbers in terms of the actual patient sample compared to the trial itself. We thought it was important to look at these log files to try to understand what we could from them. But again, I think most of the actual use that perhaps it was impacting outcomes in the trial came from just that the use of the icon on the patient list.
Thank you. Got it. Um, one more question. Well, we have two more questions. One from Alex Gazetta. Did you track readmission rates past the 30-day interval?
No, we did not. And so readmissions were a secondary outcome of ours, but they weren't statistically significant in terms of a difference. And yeah, we didn't go beyond 30 days.
Got it. And our last question, I believe. Yes, our last question from Dr. Oh, yeah, from Dr. David is, I think you mentioned some factors as drivers of risk scores, if I understood correctly. Can you say what those factors are? Are these principal components or biomarkers or vital signs?
Yeah, I don't see the question, and I'm just wanting to make sure I understand it. Is it in the webinar chat?
Yes, it's from Dr. David.
Oh, okay, I do see it there. Okay.
It's in a separate.
Factors of risk. Okay, yeah. I think I understand what you're saying. Okay, so we found it important early on so we felt it was important to build out this detailed prediction page, right? Screen, excuse me. And this was certainly when, work around AI and predictive models was saying you can't have a black box. You need to, show the information in it for explainability. And so that really drove, and this was like 5 years ago, us building out that screen. And so in building it out, we said, well, how do we boil down the features in our model into, something we can display? And so we collapsed some of the features into these 5, what we just called factors. But what these features are, is they're essentially the metadata that we're tracking from the nursing documentation. So no, they're not biomarkers. And it's metadata of vital signs. It's not the vital sign itself. So it's the fact that if I'm Nurse Sarah and I recorded the patient's blood pressure and it was 120/80 and it was normal, well, the metadata is that I went in, at least for me here on the East Coast, and when it was 6 p.m. and I put that into the record. And so you have that I recorded a blood pressure at 1 p.m. And so those are the features in the model, really, that there was increased documentation of vital signs, maybe just of heart rate, of blood pressure. Another one of those features that is a strong signal is that I put in a comment associated to a vital sign. So the best example I have always found, and it's been the same example for years, is you'll often find nurses put comments. These are, for clinicians, they might know what I'm talking about. If you don't, it's about the size of a short text message. You right click on the structured field in the flow sheet, and you can just put a little narrative, text message size. And so the typical example is, well, okay, patient's oxygen saturation is normal. It's been normal all shift. But guess what? They were 2 liters nasal cannula when I came on, and now we're up to 6 liters nasal cannula, and we're working on going to get a non-rebreather mask. Very important context to convey, that nurses convey typically in these comments, because those structured fields in the EHR, there's not a good linkage between the patient's supplemental oxygen and their actual SpO2. And that's a huge gap right there. And so the nurses do make the effort to draw those linkages. And comments are the best that they really have, the best way that they have to do that. They can write it in a note too, and certainly do. But the comment metadata can tell you a lot. And that's the feature in our model. It's really not the content within the content. You do see things such as MD aware. And yes, that has a signal to it. But what's most interesting is it's the metadata features that have the strongest signal as a predictive, a predictive feature. Then,
yeah. I mean, it makes intuitive sense as a clinician too, because it's a higher level signal that
Yes,
clearly
yes,
the pattern here, you know, 2 liters to 6 liters and
yep,
clear, then there's the eyeball test and all these things that go into whatever the
yeah,
CNS does to say increase support, increase
yes,
attention, pay more, high level. So
yeah.
yeah.
I'll add one more thing. I mean, we do have, a flavor of the muse in our model, which actually processes the actual,
Mhm.
vital sign values. It's a real simple algorithm there of, essentially normal or abnormal vital signs. But that's really just to make sure we're aligning later on in the patient's trajectory so something wouldn't look different in the score in a way that would confuse a clinician. And we're very consistent with that, um, with aligning with it. Um, my point is that's not an early enough prediction. So the features that we're talking about here, these metadata features and these patterns, are what allow for that prediction up to 48 hours before the event, as opposed to 6 hours before the event. And so while we do incorporate the actual vital signs, those are really not informative until it's overall very late to intervene on the patient at that point.
And it's amazing that you're able to capture something so complex as a signal that can be reproducibly captured. So
Yeah,
that's yeah, must have been extremely challenging and rigorous to get there, but amazing that you did it.
yeah, yeah.
Um, Rachel, I didn't want to preempt you. Did you want to transition to the
Sure. Yeah, that's all the questions that we have right now. Thank you so much.
very good. Wonderful. Well, thank you. So this actually sets up our next session, which is the Ask the Professor, Beat the Bot session, where we pose a question to open evidence relevant to the lecture. And I really appreciate that you've made all of these, um, the platform and the process accessible to other health systems. This question is, how can we transport to other health systems the machine learning algorithm to identify deterioration risk used in the concern trial and scale it to all hospital units? So we're going to type this, push enter, and then as a ready baked oven, get the answer next. Okay, and then the succinct answer is transporting and scaling concern requires three core elements: technical validation, centralized monitoring, and standardized workflows. Okay, number one, technical. Validate the algorithm at each new site to correct for site-specific biases. I don't know what FHIR and HL7 are, but they are some standardized formats. Do those make sense to you?
Those are interoperability standards, and we did use FHIR. Yes. Yep.
Most health systems use native EHR vendor configurations for deployment. Okay. So that would be Epic. That's what we have. Organizational, centralized monitoring with a virtual team of nurses who alerts 24/7 and coordinate with hospital-based rapid response teams. I do think that our system has a system based on um, dashboards that is actually developed by biomedical informaticists here to drive a lot of this staging up of ICU admission with frontline dashboards. And Kaiser does this across 21 hospitals. Okay. You agree that's part of the process of?
Well, we don't use that process.
Okay.
So it could be an approach, a centralized monitor that has some nurses monitoring with, virtual monitors, right? They're not on the unit, they're monitoring all the patients and their vital signs. It's an approach that could be used. We've discussed it, but we didn't. We went direct to, the bedside nurse, if you will.
Right. I'm not sure that we have a panel of nurses in a control station somewhere where they're doing this either. Okay.
Yeah.
Next, number three. Thank you. Implementation, clear alert response workflows, standardized documentation, interprofessional oversight teams, ongoing staff training, and Okay. All right. And then Open Evidence provided the CIFR framework as an example of how to do this and really understand the inner setting, as well as addressing the external factors, our competitive healthcare market, cost drivers, um, and then the process of doing this using implementation science principles. Okay, now what we'd like to do. So, what do you think, Sarah? Does that look like a
You've
reasonable?
asked me.
Is that
Um,
informative for the newbie?
So, well, what's so interesting is, so we do have the CFR framework in
Okay.
our most recent funding to evaluate from an implementation science perspective. So yeah, I think, there's some on point there. Interesting, some of the implementation stuff they said, we talked about that already, that we don't do the virtual nurses. I guess it just pick out from the prior slide around actual implementation. I mean, it did pretty well. It got to importance of training. I think it was saying, yes, we did do training of our end users. I think to me, it will be interesting as time goes on and there are more predictive models implemented and more, use of AI. How do we train to all those? How do we scale that type of training? For one model, certainly, and we're a research team. We like to say we're small but mighty, but we were on the units doing that training ourselves. How to operationalize that, I think, is an interesting question.
Great, thank you. Okay, and now to the audience. Rachel, do we have okay. So we have 3 questions, and this is an internet poll where we would like to encourage all of you to participate. And the 3 questions are the following. First, how precise was the AI answer? From 0 to 10, 10 being the most precise. 2, how much did the AI answer expand your thinking about this topic? And 3, how much did the AI answer help you focus your thinking? Convergence. And we'll put that up there for about a minute. I think panelists are not able to vote. I really wanted to, but.
Me too.
All right. Rachel, I'll let you cue whenever you think it's ready. Are people responding?
Yes. I think we might be about ready. Here we go. There you go.
Okay. First question, how precise was the AI answer? So I'd say the plurality said it was 7 out of 10. Fairly precise, fairly good precision. Okay, not bad. On how much did it expand thinking? So, well, divergence of thinking is spread across a range of ratings. So, but in general, pretty well. Think a little more broadly about this than just getting a data use agreement signed and going to town. I think there's a lot of factors that definitely need to be dealt with. So it helped me think about those things. And 3, how much did they help you focus? Okay, it helped a little bit, let's say. All right. Okay, well, I'd say that would perform pretty well, although, like you said, so kind of mix, right? There's some of that is not so simple, right? To just have a Star Trek spaceship with all the nurses in one place, like monitoring all the data 24/7. I don't think that's going to happen.
Yeah.
But I think coordination of assimilation of these data as they come in, some nursing leadership is key to making this even possible, and working with a team. Sure. Okay, so that was fun. All right, so the next thing we're going to do, Rachel, do we have so I think that this work has stimulated a lot of thoughts about from a research standpoint for me, for example, and we would like to have your feedback on the value of this educational experience for all of you. So please do fill in this survey here. but one of the things is that I do work in pharmacogenomics, and we don't really capture a lot of things that are early signs of adverse drug reactions that we might want to capture as phenotypes. And this has made me think about how to model this work before patients show up in the ER, before they show up in hospital readmissions. And so I'm really curious to know how we can get patient-reported signal too. And there's a lot of examples of how that was done during COVID with symptom apps and things like that. So this has really stimulated my creativity about where to go with our pharmacogenomics readmission work, working with bioinformaticists here, but also at Vanderbilt where we're collaborating. So maybe we could follow up on that.
Oh, yeah.
But thank you all very much. And please do give your feedback here. We'll keep this up for a little bit. Rachel, are people filling these in?
They are indeed.
Excellent. And again, thank you very much, Dr. Rossetti, and enjoy springtime in New York.
Thank you. Thanks so
Happy
much for having me.
Day.
Yeah.
And our next speaker will be Dr. Matthew Thompson from Google Health, who will be talking about agentic patient-centered medicine and how we can transform healthcare. So thank you all very much. Rachel, do we have anything left to cover?
We do not. Thank you,
Any
everybody.
feedback? Yeah. Thank you, Rachel, as always, for making this possible.
Very welcome.
And we'll see you back next month. Thank you, Dr. Rossetti. Okay, bye-bye.